Hello, everyone, and welcome to our Grand Round series. Our Greenberg bladder cancer team members are grateful you are here. Of course, we'd prefer seeing you in person, but given our ongoing response to managing the SARS-CoV-2 pandemic at Hopkins and in our own local communities, these virtual platforms have proven to be an efficient means of sharing information, education, and discussion. First, a couple of updates. Later this month, we'll be releasing our winter and spring calendar 2022 virtual monthly programming. For updated information about the Institute, be sure to simply Google Greenberg Bladder Cancer Institute. Further, I wanted to once again draw your attention to our evolving group of programs specifically tailored around the experiences of women with bladder cancer, developed and led by doctors Armin Smith, Jeannie Hoffman-Sensis, and the program team of Pamela Getz, Samantha Rockler, and Stephanie Cooper Greenberg. Their next program is Tuesday the 14th and will be a conversation on life with and after bladder cancer, featuring a very well-respected panel of contributors. Their programming details are also available on our website, and of course, please never hesitate to reach out and we will send you the details directly. Again, all of this information and more is up on our website. And if we can help you directly, we are only an email away at bladdercancer@jhmi.edu. Today, I'm happy to be sharing the stage with our clinical co-director, Dr. Noah Hahn. And we're both very grateful that you're joining us for this overview of tumor sequencing. As you hopefully all know by now, Dr. Hahn is a medical oncologist, world leader on bladder cancer, and brings an important clinical perspective to our conversation. I would ask folks to please submit questions via the chat feature. And after our conversation, we will have ample time for group discussion. And for those of you who are worried about this, I'm not showing any slides of gels or heat maps. We're going to keep this a very general discussion to leave plenty of time for interaction with all of you. So just by way of background, let me make a couple of points about what we're talking about today. So you probably all know this by now, but I think it's important to kind of go over it anyway. So why are we doing sequencing? So for clinical purposes, we're sequencing DNA. And the reason we're sequencing DNA is that mutations or changes in DNA sequences, we think are the causes of cancer. They may or may not be the only causes of cancer, but we have good evidence that they contribute to the development of cancer. So there are different types of mutations, and it's important to understand the differences between them. So in some cases, these mutations in the DNA target genes that activate cell division, that activate cells to divide. And these mutations we call oncogenes. And a good example of an oncogene that you're probably familiar with in bladder cancer is FGF receptor 3, the target of the drug erdafitinib. Mutations in that gene cause cells to divide when they shouldn't. And the reason that erdafitinib and other drugs like it work is they block that process. They block the cells from dividing. So those are called oncogenes. And the other major class of mutations that we think about are called tumor suppressor genes. So in this case, the mutations inactivate these genes. And this is because these tumor suppressor genes block cell division. And so when the gene is inactivated, then cells can divide just as they would when these oncogenes are activated. So they kind of have the same effects on cell division. A little more complicated than that, because a lot of these tumor suppressors also function in DNA repair. And so when these tumor suppressor genes are inactivated, it causes cancers to accumulate even more mutations. There's also relevance, we think, for, as you probably know by now, because we talked about it so much, treating patients with chemotherapy and immunotherapy. So a good example of a tumor suppressor that you're probably all familiar with is BRCA1 and its relative BRCA2. These are genes you've heard about, I think, because they are associated with hereditary risk for developing ovarian, breast, and certain other cancers. And again, in this case, the mutations are inactivating these genes and predisposing patients to these cancers. For our purposes, there's another class of tumor suppressors that's really important. And this is a group of genes called mismatch repair genes. Mismatch repair genes are defective in Lynch syndrome. And as you all know, Lynch syndrome is linked to upper tract urothelial cancer. So here at the Greenberg Bladder Cancer Institute and at other institutions across the country who are working with patients with upper tract cancers, one of our major initiatives is to see whether or not the patients we are seeing with upper tract cancers have mutations in these Lynch syndrome genes. Now, there's one other concept that I wanted to talk about before passing it over to Noah, and that's the difference between somatic mutations and germline mutations. So somatic mutations simply mean those mutations that arise in the cancer itself, but are not present throughout the patient's body. Those somatic mutations are not going to be the cause of hereditary cancers, but instead they are important to us because they can guide our decisions about choosing therapies. Germline mutations, on the other hand, are mutations that are present at birth. They're inherited mutations. And these mutations we are very concerned about for tracking risk of developing disease. And in some cases, these mutations can also tell us something about a patient's potential response to certain therapies. So again, this is an ethical question for us too, because whereas if we sequence your cancer and we find somatic mutations, that has important clinical implications. As long as we stop there, the rest of your family doesn't necessarily have to worry. On the other hand, if we sequence your cancer and cells from another part of your body, such as your blood that we think isn't affected by cancer, then if we find mutations in those normal cells, then that suggests that you may have an inherited predisposition to cancer. And of course, that has implications for your children and other family members. And some people want to know this information, and other people don't want to know this information. And so this is part of what we do when we do informed consent. So I'll stop there and turn it over to Noah. We'll talk more about this.
Sure. Thanks, David. And thanks again for everyone at the GBCI for helping us set these up, these sessions. I think these are really an effective way for us to reach out, in times when we can't be together in person as frequently, although I'm hoping that will not be that way forever. Some things are starting to come out, but we're going to have to see what happens with some of these variants through the winter. But that being said, as far as the sequencing aspect goes, from my perspective as a clinician who sees patients and who counsels patients and families about what we're talking about, I think I sort of start from simple terms and try to keep it that way. It's a complicated topic, and I think even us as oncologists and bench-based researchers who are in this every day, there's still some terms and terminology that I think even we get a little confused with. But I think in general, when I talk with patients about sequencing, what I'm talking about is trying to get some additional information about your particular cancer that can help us guide therapy options and potentially therapy choices. David mentioned that we're talking mainly about looking at the DNA. We throw these terms around pretty frequently between DNA, RNA, genes, proteins, and transcription, all sorts of things. I kind of like to think of it in again, real simple things as, I grew up in the Midwest. I grew up in steel country, auto country, and so cars were kind of a big thing. They still are. And I think about genes as parts to a car. You need all of the parts to the car to be assembled to actually get a functional vehicle goes where you want to go, when you want it to go there. And you can think about an individual gene, you know, in our body and our cells as a part to a car. You know, one gene could be a door, one gene could be a tire, another gene could be a piston in the engine, another one, you know, the fuel line, etc. And having a nick or a bruise or a dent or a break, you know, in a certain part of the car doesn't necessarily mean that the car is not drivable. If that were the case, I would not have been able to get around pretty much anywhere in high school or college. So when we take a piece of a patient's tumor, we're kind of taking an inside look at all the pieces of the car that make up that tumor. And we're trying to understand, are there any advantages or breaks in those pieces of the car that give the cancer an advantage as far as how fast and how far it can travel? But are there also maybe some weak spots that maybe we can target with drugs to really disable that car? And if you think about it that way, it's not so much the number of dents or nicks you've got in the paint job or under the hood. Sometimes it's really about which critical ones, you know, are broken. So if you take a car, for instance, if you just kind of think about it like in an army or something, if it's in combat and it gets kind of hit up with a couple different bullet holes, if it's in the right place, if you only get one shot, you know, to the radiator in the right place, the whole car can be disabled. Whereas sometimes you could have something maybe spraying throughout the trunk or something and not causing it. Relevant to bladder cancer, though, I think why this is critically important is that we now have a drug that is approved by the FDA called erdafitinib that is specific to cancers that have activating mutations of the gene FGFR3. And that is only found in about 15 to 20% of metastatic bladder cancer patients. It is, however, very frequent in early stage bladder cancer patients. And so I look at that from a therapy standpoint and also counseling patients and families is really it's the first sort of foot in the door and opening true precision approaches to individualized therapy plans for our bladder cancer and upper tract patients. And that's incredibly important because we've never had that before. Other cancers have had that for a number of years. What that means for us, it doesn't mean that FGFR is going to solve all of our problems in bladder cancer. But what it has done is it has made genetic sequencing of bladder cancer tumors for patients become an accepted standard of care. And so from an insurance standpoint, sequencing of a patient's cancer is typically paid for by insurance. It's not something that we have to, you know, have patients self-pay thousands of dollars to get that information. And it has direct therapy implications. And so that has also attracted increased interest, investment, and trial launches from pharmaceutical and industry sponsors, because it's been proven with erdafitinib's effort that, hey, if you do the science, if you bring a drug forward that is, you know, specifically targeting a group of patients with a very specific genetic makeup in their cancer, then we can improve the outcomes of those patients. And I think that's pretty exciting. I think I'll kind of stop there, you know, again, from my perspective, but I think we're seeing more and more of this happening. And I think really what we'd like to do in this particular session is try to answer, really almost make this an open forum. There's a chat room for questions for people to enter questions. Me and David can sort of field a couple back and forth, but we'd really like this to be a resource for everyone online, because again, there's a lot of terminology and sometimes some confusion, sometimes some urban myth or dogma, I think that's sort of, put out there about sequencing, and we'd like to sort of debunk that if we can.
So Noah, maybe I can ask you this question. When is it appropriate to use sequencing when you're managing a patient's cancer?
Yeah, it's a good question. Well, from a standard of care standpoint, I would say all metastatic patients, if there's tumor tissue available, it's the standard of care is to send some of it for sequencing. It is also, I think, appropriate to think about it in patients, for instance, if they are in the perioperative setting, so they had a cystectomy or nephroureterectomy for their bladder cancer, upper tract disease, and let's say they have very poor risk features. So they have a very large tumor that's advanced through the wall of the bladder, or it involves lymph nodes, in whom they have a very high chance, greater than 50-50, of their cancer coming back. We tend to send that for sequencing at that point. And one of the reasons, I think, from a patient perspective, that's also important to know, the reason that we here at Hopkins tend to send some of those tumors early around the time of surgery is the actual testing to get the information back from any of these platforms that are available. It takes several weeks. So it's usually about 1 week or so at the institution that did the surgery to get the requisitions, to go get the tumor block, get some slides cut from that, and then get it sent out the door from your institution to the lab that will be performing the sequencing. And then once the lab that is performing the sequencing has the tissues, it does take about 2 weeks to turn it around. So it's in the patient's best interest to sort of have that, as well as the physician, to have that information ahead of time for treatment planning, rather than wait until disease comes back, or if someone is in a metastatic setting, wait until their cancer may demonstrate that it's no longer responding to their first treatment. Because in that situation, it's just really hard to wait. Sometimes patients are not having symptoms, but it's really hard from an anxiety and anguish standpoint to just not know. Constantly asking, is it back? Is it back? And I think that's just tough to put people in that situation.
So Vicky has a question. Are there more mutations that can be tested for that have treatments identified that aren't necessarily FDA approved?
Yep. Yeah, it's a real good question. So we touched a little bit just on the one singular gene, FGFR3. Most of the time when we talk about sequencing, there are probably 3 to 4 major commercial labs in the United States that our insurance will cover. We are typically testing for alterations in a panel of very common altered genes in cancers. And those panels can vary, but they generally cover anywhere from about 300 to 650 or so individual genes. So when we send a tumor on those panels, we're getting information about all of those genes back. And that can be important for bladder cancer patients and for any kind of cancer patients to inform us about alterations maybe in genes that could be important therapy targets, but have not been approved yet for bladder cancer, upper tract urothelial cancer, for instance. So one of the things I can tell you just offhand, I've had several patients when we have sent sequencing where we have seen suggestion of increased copies of the gene HER2. And HER2 is very common gene with many drugs approved for breast cancer. It's not nearly as common in bladder and upper tract urothelial carcinoma, but in those patients who do have it amplified, it really can be driving the tumor's growth. And so in that situation, often I may look for a clinical trial, that is bringing potentially a new HER2 targeting drug into the clinics. In some cases, if there's not a clinical trial near them or they would not qualify for, I can sometimes make a case for the patient's insurance to see if I can get it covered. And I've had some success with that. It's patient to patient. Not everybody does cover it. But that's one approach that I look at, for instance, for genes that do not have therapies approved for bladder and upper tract urothelial carcinoma yet. And I think many of the clinical trials are trying to use that approach to match patients to therapies that they hope may help them.
So Stephanie has a popular question for us. Is sequencing covered by insurance? And I think you partially addressed that just now.
Yeah.
Expand on that. Can you
Yeah.
ask for sequencing if you're at a urology practice or an academic medical center?
Yeah, those are two questions. I'll kind of tackle them both. So on the insurance side, I think it's always best, I think, for the patients and families to, have that discussion with the physician, more importantly, with kind of their financial clearance and how they do that. I can tell you from our standpoint at the GBCI, we've worked with a lot of the different commercial labs, and we've been fortunate in that we've had some different relationships with them, where on a research side, we've been doing some collaboration. So we've been able to work out some collaborations with them where they have wanted us to send, sequencing of many of our patients, and have developed very good and very accessible financial assistance programs. That sounds nice on paper, but at the bottom line, if you're asking to have your own tumor sequence, they say we have a financial assistance program, and then you walk out the door, you're sitting in the car on the way home, and you're like, I don't know what that means. Does financial assistance mean they're throwing $5 into a pot that costs $5,000, or does it mean they're tossing $49.95 in and I have to pay $5? And I think that that's an important sort of consideration. Most of the companies that we have worked with recently, I will tell you, and I don't want to get into specifics because it changes a little bit, but we've had agreements with some of the companies we've worked where they've guaranteed that the out-of-pocket max to a patient would be $100 maximum. Some of these, I would say, offers, so to speak, when some of these companies come forward, don't get anyone confused. I mean, there's a business perspective of that, and so they want to generate sort of workflow. There's never a written guarantee as to how long, for instance, those types of offers will stay in place. We've not seen, thus far, and I'd say the last 5 to 6 years, as several of these companies have come online, we've not seen any issues where all of a sudden, those cost assistance or very small, maximum out-of-pocket costs have dramatically changed. And I think it'd be not in the best interest of any of the companies to sort of do that, because it's a very competitive market space. And if there was, one company that all of a sudden sort of pulled the rug on reimbursement, they'd probably be finished pretty quick, because there is more than one option out there. And I think both patients and providers can switch pretty quickly. The second question, I think, was about the urologist or the urology practices.
Yeah, if somebody wants sequencing done, can
Yep.
you ask for it at a LUGPA kind of urology practice?
Yeah.
Or how about an
So-
academic medical center?
Yeah, so anybody can ask and get sequencing done on their tumors. The question is, if it's early stage bladder upper tract urothelial carcinoma, does it fall within right now Medicare payment sort of guidelines? Most of the Medicare payment guidelines for the panels that have been approved so far are generally in relapsed or metastatic cancers. Now, metastatic, I think that's fairly obvious. It's spread outside of the organ, the primary organ. The relapsed is a little, I would say, a little more open for interpretation. And that's where I think there's a gray area as to when we move into early stage cancers, typically seen, for instance, in urology practices. If a patient wants to get their tumor sequenced, let's say it's non-muscle invasive bladder cancer. Sorry, I got to turn this off here. It's non-muscle invasive bladder cancer, and it's the second tumor that they've ever had. The first one they had, let's say, a year ago, the urologist just went in, did a TURBT. It was gone. They did not get BCG. And then a year later, they come back and let's say they have another non-muscle invasive bladder cancer tumor. You could argue that that's relapsed tumor, and should be covered by some of those guidelines. But I would say that that's an area that I think makes a lot of people uncomfortable, even as physicians, because we cannot guarantee, to a patient and family that the insurance would see it that way. So because of that, I would say we're not yet seeing sequencing offered and performed that often for our early stage patients. At the GBCI, as I mentioned, we've had collaborations with a lot of these companies. And so that's one of our efforts here, is to try to do that. And a lot of times we're trying to do that under research sort of collaborations to make sure that sort of the cost issue is taken out of the equation. I do believe that we are going to see sequencing move into early stage bladder cancer. And I think we're sort of right on that kind of transition point right now. But I would say it's not been 100% defined yet.
This is a related question that Margaret has. So would you sequence T2 tumors that have penetrated the bladder wall but not yet gotten out of the bladder? If not, why not?
So I would definitely sequence them if that patient had gotten neoadjuvant chemotherapy, because if they've gone through, and again, I think for this audience, many people know this, but I'm talking about if they've gotten chemotherapy prior to surgery in the hopes of downstaging or reducing their tumor. We've seen from prior studies that if patients have gotten chemotherapy and gone to surgery and they still have muscle invasive cancer or greater, they're at an even higher chance for metastatic disease to develop, say, in the next 12 months than a patient who just went straight to surgery and had not seen chemotherapy yet. So that suggests to me that they've got an aggressive, potentially resistant cancer. So I would sequence that patient. If they went straight to cystectomy and they are a T2N0 patient, I can tell you I want to sequence them. That's sort of right on the edge of whether or not traditional insurers would cover or not cover that. So if I were going to send sequencing on that, again, for us, we would have to get financial clearance ahead of time to know that, yes, that would or would not be covered. And I would say in that situation, it's probably going to be about a 50-50 in terms of, depending on sort of payer makeup and sort of how they interpret sort of the FDA guidelines.
Thanks, Noah. We've got two questions now from Rick Bangs. Thanks for joining us, Rick.
Yeah.
So how much might sequencing reveal about the cause of my cancer? Would it expose a smoking-triggered primary or secondary bladder cancer, hairdressing, or other environmentally caused bladder cancer? Maybe I'll take a stab at that one.
Yeah.
So these days, as a result of doing research sequencing, we're often looking at the patterns of mutations that we see for so-called single base substitutions, or SBS signatures. These are now being correlated very well with certain exposures. So there's a single base substitution signature that's associated with exposure to ristolochic acid, which is this natural product that is in some Chinese herbal medicines. And so as a result, we can see evidence that people have been exposed to that when we sequence their cancers. There is an indirect idea that smoking might be associated with certain other signatures, although that hasn't been really validated well yet. And also signatures associated perhaps with alcohol exposure and alcohol metabolism genes in patients with upper tract cancer. But yes, in theory, we would be able to see scars, if you will, mutagenic scars of exposures to, in theory, any of the mutagens that people might be exposed to, including hairdressing and other environmental chemicals, and maybe even UV. There are people working on a number of different things in that area. So it's early, but yes, we do think we'll be able to see cause effect. And for Noah, this is a question for you. If I have sequencing expose additional cancer risks Is my insurance coverage at risk going forward? Two really good questions.
Yeah, I think that's a really good question. I think most of the sequencing panels and companies that are offering this have sort of hedged and gotten around that a little bit, in that some of the technologies that are available only test the patient's cancer, so their tumor tissue. And so by doing that, they cannot sort of qualify or credential any of the genetic alterations that they find as saying that they could or could not be inheritable. And it's sort of a layer of anonymity, if you will, to kind of say, look, here's the mutations. And they often will put in their report, like, let's say, for instance, they find a gene like BRCA1 or 2 that is associated with hereditary breast and ovarian cancer. They often will say, this may be a potential, germline or inheritable gene, would recommend additional like genetic counseling in appropriate clinical situations. They basically just boot it back to the physician and the family. In that situation, it's hard to sort of make a case that that establishes, for instance, a pre-existing condition, because it really doesn't say one way or another. Some of the other companies that are out there, some of you may have had your own tumor sequenced. They may ask for a saliva specimen or a blood specimen. And in their platforms, they are sequencing, our baseline white blood cells or cells in the hair that are, you think about would have our normal inherited DNA. I use the term normal really, really loosely because honestly, there's no such thing as normal. We all, have thousands and thousands of alterations in every gene that we're born with. It makes us who we are. What they use kind of the saliva and the hair sample for, in simple terms, they're going to test the tumor tissue for genetic changes. They're going to test the normal tissue for genetic changes. And then I like to say they subtract the normal genetic changes from the tumor genetic changes to sort of see what is truly only found in the tumor. And that's what they report. They will not go in their report and say, you have a definite germline inheritable BRCA1 or 2 mutation. They again will put asterisks in there, like recommend genetic counseling if you think it's appropriate. So to answer the question about whether or not it will change the insurance sort of risk and that kind of thing, from a like pre-existing, like it puts you at risk for, puts you in another class for other tumors. The only way they really can do that is if the patient or families choose to go through with the genetic counseling, and after they've had that, they choose to then have the formal sort of, we call it germline testing of the blood or saliva to prove that you have an inheritable genetic cancer risk. And I think, different families want to know that, different ones don't. But they should not be able to change your insurance sort of coverage just by having sequencing of your existing cancer. It's a big, big fear. I can tell you in my 15 plus years of, oncology, of which I'd say sequencing has been a part of it probably for about 10. I don't have any patients or families yet that have come back to me, and said that they have run into that problem. It doesn't mean that that hasn't happened or somebody doesn't have it. I just haven't had that come back as a frequent issue that people have come back to me to. I do have patients and families who still are, worried or concerned about it. David, you and I have talked about this even on the research side. Sometimes in the lab, you need some normal blood just for kind of reference. And I've always said, I don't want to know. I don't want to know. I don't want to know a genetic change in a disease that I can't change yet.
Yeah.
So, people are on different sides of the fence on that, but I don't think that it should be a major concern at this point. Again, I also understand that's still a lot easier for me to say on the ordering side of the testing compared to, being affected by it.
So Noah, here's another question for you. Daryl Murray asks, can CIS be sequenced? What is the process difference between CIS and papillary biopsy?
Yep. And so for everybody, just to make sure we're talking about the same thing. So carcinoma in situ, or CIS, is generally considered high grade bladder cancer, but it's non-muscle invasive. And what's different about carcinoma in situ is that we're really talking about just a couple layers of cells. So this is not what we call a papillary tumor looking like a stalk of broccoli kind of protruding into the bladder. It's not a tumor that's invading deep into the muscle. It's just along the surface of the bladder epithelium. And because of that, when you look at a biopsy or a TURBT that has only carcinoma in situ in it, you can send it for sequencing, but you have to sort of be pretty meticulous about knowing how they're going to process the tumor tissue. If their standard process is for pathologists to circle an area of tumor and then just scrape everything off of that slide, they'll send you some sequencing results, but most of the tumor cells that are going to be sequenced are actually not going to be tumor cells. They're probably going to be the underlying blood vessels, immune cells, and things underneath those layers of CIS. Because of that, there's been a long-standing belief that it has been difficult or maybe not possible to do modern genetic sequencing on carcinoma in situ specimens. That's been a real interest of ours at the GBCI from both a research and a clinical perspective over the last, I'd say, 4 to 5 years. And we've been doing some work with several companies asking that question, sending them specifically specimens that are archived, just paraffin slides that we know were carcinoma in situ, and they may have a new technology, and we would just want to see, all right, let's send you 30 or 40 of these specimens, and you tell us how many of them you can get good, high quality sequencing data back. And then on the back end, we're also doing the same thing, here at the GBCI. And what I can tell you is, in our hands, you can sequence carcinoma in situ, but you do need technicians who are really good at what they're doing, who understand, when you mark the line of CIS, that are able to kind of dissect that off very, very meticulously. I would say it's more helpful when the specimens are fresh or current. They don't necessarily have to be fresh, like right out of the patient, frozen, never put in paraffin, although that'd be great. But you want to work with samples if you're going to sequence them that are not 10 years old. And we've been able to do that. So we're pretty encouraged. We've been working with some small biospecimen platform type of companies, and we've seen the ability to sequence CIS in about 85% of the patients. So one of the things that we are doing right now is we're doing sort of a separate project where we're really trying to understand what did they sequence. So we're going through the exact same slides and really trying to parse out only the CIS cells, and then look at kind of the vascular cells and the immune cells underneath, and see, do those signatures that come out from the genes that are found in each of those, are they the same or are they different? Because that will ultimately tell us if we can do this more commonly. And I think the question's pretty timely, because in the non-muscle invasive bladder cancer setting, the carcinoma in situ, or the finding of it, it really does drive clinical care, and it's driving drug development. And so our ability, to study carcinoma in situ is going to be critical for us to design better therapies.
Thanks. So next is a question from Stephanie that I think I will take. She asks, at the GBCI, it is assumed that you sequence samples in the lab for research. Is the sequencing you do for research different from the sequencing you do that is sent out? And the answer is a partial yes. So in the GBCI, we use a platform called Oncomine, It's a platform from Ion Torrent and Thermo Fisher. It's the same clinical platform that was used in the NCI's MATCH trial. And it's also offered as clinical sequencing in a number of institutions. We don't use it for clinical decision making. We are doing it in our research laboratory, and there are rules associated with sequencing, where it's done and how it's done, so-called CLIA standards that are required for those sequencing results to be used for clinical decision making. But the platform we're using is the same platform as other institutions use for clinical sequencing. And one of the reasons we're using it is we can use very, very low amounts of DNA and get accurate results. So to the point Noah was just making, we're also really aiming to get higher sensitivity in our sequencing so we can do things that maybe other people thought weren't possible before. Now, with that said, we're taking the same workflow and we've designed our own custom bladder panel. And with that, the overall analysis is the same as Oncomine, but that's a pure research platform. So that we're doing because we can sequence for a lot less money. And so for research purposes, the Oncomine platform has genes that are never mutated in bladder cancer. And so we can kind of focus on the ones that are mutated in bladder cancer and reduce the cost. And then this one's for you, Noah, that's a corollary of the question. Do you see a time in the future when all solid tumors, or almost all, will be sequenced routinely as part of clinical care?
I would say yes, but I think the way that we sequence individual patients' cancers may be different. And so what I mean by that is right now when we do these panels of 300 to 600 genes, and we're looking at all of these genes for an individual patient, we have to use a fair amount of tissue and a fair amount of DNA in that process in order to get enough purity to be able to feel confident about making the calls of which of these genes are altered. And it may turn out that from a therapy standpoint, again, let's think like 5-6 years down the road, and in bladder cancer, we haven't parsed out bladder cancer and upper tract urothelial carcinoma into very distinct molecular diseases that we treat and approach differently. So instead of doing sequencing on a tumor where we're looking at 600 genes, kind of searching, trying to find any, alteration that might have a drug, that can target it, we may narrow that panel down and say, okay, again, using let's just use FGFR for an example, since it's the one that's approved in bladder cancer. We may be ordering a different FGFR sequencing in everybody. So instead of a panel based where we're looking at 600 genes and all the genes, where it has a certain amount of resolution, if you will, to be able to find changes in each of the individual genes, we may find out that it's really important to identify a certain kind of FGFR alteration, particularly in patients, let's say, that were identified up front and went on to an FGFR therapy, and then we're starting to see cancers grow again. So there may be a different kind of test that we order in that situation, that may be an ultra-sensitive FGFR sequencing test, where we're more interested specifically in the types of FGFR mutations that have evolved or changed. I could see that happening a little bit differently. It doesn't help, I think, patients and physicians to sort of do a little bit more of just kind of the searching type of an approach if we don't have, meaningful therapies to match them to. And so I think the FGFR story was the first step in that direction. And I think as additional genetically selected therapies prove their merits, in urothelial cancer, I think our sequencing and the way that we do it may change accordingly. It may be that, we hone in on maybe a smaller number of genes, but more sensitive up front, to make sure that we do not miss the opportunity to put somebody on something that could benefit them and then maybe we do the more expansive sort of sequencing, later on if it looks like those therapies are not working. But it's a rapidly moving field. So my version of science might turn out to be science fiction. I don't know. We'll see.
I like your version.
Yeah.
So Vicky asks, have any prevalent bladder cancer mutations been identified as more and more tumors are sequenced? Seems to me the more tumors that are sequenced, the more data there would be. These could become new therapeutic targets. So you're right, Vicky. There is a very long list of genes that are mutated in bladder cancers at very low frequencies. And so the more tumors we sequence, the more of these rare mutations we find. Precisely how they might contribute to treatment decisions is going to be difficult to tease out, because those of us who write grants oftentimes get criticized if we're not studying a gene that's present at a high frequency in cancer. And so if we're studying a gene that's less than 1% or even less than 10%, it's hard to understand its function. But in theory, yeah, I think that there are therapeutic targets in there, and more research needs to be done to see how we can exploit them. Lori Summerson asks, if you sequence early, could the results change down the road? For example, several years from now. I'll turn that over to you, Noah.
Yeah, they absolutely can change. I mean, we've seen some early results from some of our friends and collaborators at other institutions where they've done comparison of original tumors to tumors that were seen at autopsy in patients. And it's pretty clear that there can be additional mutations acquired, sort of branching from maybe an original tumor. What's not talked about as much also is that sometimes some mutations are sort of lost a little bit, that were found originally and then are no longer there. And that can have therapeutic implications. So in the clinic, I can tell you that I do send repeat samples to sequence the new tumor, and I'm doing it with increasing frequency, provided that there is an accessible site of tumor that can be biopsied or sent. The area when I will do that pretty frequently where I really want it is if you have a patient who went on to an initial therapy, whatever it be, whether it be chemotherapy, immunotherapy, FGFR, et cetera, and they had a really good lengthy response to it, feeling well, disease very well controlled. And then I see not all of their disease starting to progress, but maybe I see an isolated lymph node or an area or a lung met that just seems to be growing on its own. That usually piques my interest to sort of think, hey, maybe something's different happening with that particular area of cancer. So if I can, I try to get some tissue from it and send it to see if anything's changed from, a genetic standpoint. But it's tricky. So when you think about doing a core needle biopsy, of a tumor tissue, we're typically talking about a 1 millimeter diameter piece of tissue. So if you have a 2 centimeter lymph node, just a little bit over, well, about an inch, you could punch, 25 needle biopsies along the length of that tumor, and then just as many rows of 25, by 10 or 15 down if it's a centimeter and a half wide. So you could, in theory, only be sampling, a minuscule piece of the tumor. And we've seen within bladder cancer as well as other cancers that if you were to punch different core needle biopsies of an individual tumor, that you may see different sequencing results within the same tumor at the same time. So I'm generally one that thinks that, additional information can be helpful. We're also trying to figure out how to overlay sort of the role of some of the circulating DNA in the blood or the urine, if that may give us some additional information as well. I like having more information to at least be able to try to inform that decision better. It doesn't always clarify it, but I think when it's feasible, it's probably something I'd recommend.
Thank you. And so Stephanie asks, is sequencing data aggregated for research purposes, and who would be using it? If yes, who holds the data? Go ahead, Noah. Do you want to take a crack at that?
Yeah. Well, so I would say that most of the time we are aggregating the data for research purposes. I think, as David had mentioned, even when we're doing the commercial platforms, there's power in numbers. You know, patterns emerge after you look at hundreds of patients rather than just one or two that has sort of a good response. On the back end of many of these commercial platforms, they are doing additional genetic analyses that they're not sure what they mean yet. So some of the platforms, for instance, are looking at the RNA and the DNA. So I think that's the first step towards progress and understanding, is sort of, you know, keeping track of that in a research sort of fashion. Who holds the data is a good question, and who uses it is also a good question. When we talk about this kind of data, this is no longer data that we can visualize. It's not something we can put into a, you know, an Excel spreadsheet and look at it, because you're talking about, you know, 20,000 genes, you know, per patient, with looking at many different things within each gene. So these are typically housed on cloud-based servers from a computer informatics standpoint. In the analysis and processing, you really need kind of supercomputers to be able to do this, to do it quickly and fast. Who's using the data on the research side is also a good question. It takes a team, I think, to really translate this mountain of information into recognizable discoveries, and also clinically relevant you know, implications. And so I think at the centers like the GBCI and others that are involved in this, we typically need a team of individuals, and our informatics, our computational biology specialists who know how to write the actual computer code to assess changes in these alterations, they're a critical piece of it. Our IT people, just from the hardware side of understanding how much cloud-based memory we need. And then I know David will know this, and others, is okay. First question is, what's the price tag? How much does that cost? I always kind of joke about it sometimes. It feels like you're paying for air, you know, but you are. It's got to be somewhere. But I think that's who uses it. And I think that's a real important thing, though, for patients and families and other people to understand, organizations involved in this. It doesn't help if it's just sitting there. So, you know, you really want, you want to make sure, and this is more about the research side and thinking about, you know, from a patient and family advocacy standpoint, when you're thinking about trying to support or get behind a research organization, you want to know that they're actually using it. So I think a healthy litmus test for that is just kind of ask sort of organizations just about like, you know, one or two projects that they're working on. If they can't give you one or two projects and talk about it a little bit or an example, then I'd say that's probably a little bit of a concern, because you know, there's just a lot of meaningful projects that are out there that are important for us and others to finish.
So to expand on that just a slightly, you know, the issue of confidentiality is a huge one. So we and our research partners, you know, strip all of the clinical identifiers off of the research data that we generate when we use it ourselves, and also in particular when we upload it into a public database. Theoretically, it would be possible for a really clever person, maybe with a really powerful computer, to go in and analyze those data, and maybe in some cases link them back to a specific individual. You know, you hear about some of the crimes that are solved with DNA fingerprinting that 23andMe and other organizations have done. It's very unlikely that that would happen with the kind of data that we produce. And there are strict rules around that, both at Johns Hopkins and also the federal government has strict rules around that too. But as Noah pointed out, it's really important that we share our data or we can't make rapid progress. And so it's a complicated maze to navigate to make sure that we're taking off enough information so that it doesn't risk your privacy, but at the same time share it with as many investigators as possible. And so Stephanie asks also, what does the sequencing machine look like? Well, hopefully we'll be reopened for tours here pretty soon and you can all come in and look at one. But maybe just to give you an idea, I'll go ahead and share my screen. So the most common sequencers are Illumina sequencers, and you can see a number of them right here. This one is a HiSeq 2500 and a HiSeq 3000. These are the kinds of machines that most core facilities, including the one at Johns Hopkins, use. We use a Hahn torrent sequencer, which is a little bit different in appearance, but overall they kind of all do the same thing. They sequence by a very kind of similar approach.
I kind of think, I mean, just going back in the day, it kind of looks to me like an IBM copy machine. You know, I mean,
it does.
Yeah, Xerox. Looking at it, it just, I don't know, maybe they need a little more neon or some, just jazzing it up a little, but what goes on inside it is more than just an IBM copier, but yeah.
Yeah, so we're approaching the top of the hour. Noah and I, of course, would be welcome to entertain any more questions if anybody has any last questions for us. I think the questions you've been asking today have been really insightful, really great questions, all of you.
Yeah, I think one thing that I would add to kind of the ownership question, though, just from the patient standpoint, is to just remind everyone that you own your sequencing data. So if you do get your tumor sequenced, it is an obligation for the physicians and their team and the companies that do that to provide the reports, the information back to you. So if you're having any trouble with that, you know, I would definitely recommend bringing that up with your team, because that's not something that it's a secret. It's done in your interest, and you know, so to just ask for that information for sure.
So thanks everyone for joining us today. Thanks, Vicki, for thanking us. It looks like we have one more question in the question box. Daryl asked, has there been any late-breaking updates on new treatments or approvals, i.e. Adstiladrin?
I would say relevant to Adstiladrin, no, not yet. I think you, myself, David, and the rest of the bladder cancer community, you know, is waiting on that to see. But there's not been any new information, I think, provided in the public domain or otherwise that I have at this time.
Agree. I don't have any additional information about Adstiladrin either, and I'm working on it with Colin Denny. So.
Yeah.
Okay, Sharon Akers asks, is there an opportunity to tie into quantum computer to manage and evaluate the data? Sharon, there are so many opportunities in computer science and data science. We are just scratching the surface for the way we can analyze this data. When I was at MD Anderson, Ron DePino, who's the president at the time, engaged the IBM Watson team to try to deal with the amount of data that were being generated by a lot of these projects. And you know, we have the Applied Physics Laboratory at Johns Hopkins, and other institutions have their own teams of data science and computer science investigators working on this. Yes, the answer is yes. There are many opportunities for applying more sophisticated computing approaches to analyzing our data, especially when we combine our sequencing data with all the other data we're collecting on patients. So thanks everyone for joining us. And again, reminder to all of you, the women's program is going to have another presentation on the 14th. Be safe, take care, and look forward to seeing you again soon.
Happy holidays, everybody.